I'm excited tonight. We're going to have a very, very interesting and informative program. We have two of the Albany capital area experienced cardiologists, and one of them also is an executive at an insurance company. So they're going to be able to talk about heart failure, what the risks are, the risk management, your lifestyle changes, talk about insurance, how you best to take advantage of the insurance you have, how to navigate it, the things you can do to maximize your benefits, and try to answer questions to the extent that they can about insurance. Now, everybody's policy may be different. And also, I want to introduce our moderator tonight. She is a dear friend and a super person. Her name is Linda Ordway. She's an acute care nurse practitioner at Tufts Medical Center, and has worked in the advanced heart failure program for over 20 years. Her passion is caring for patients. I can personally attest that that is very true. And while in the hospital setting, those who are critically ill and just learning about their heart failure and illness, or the progression of their illness to requiring advanced therapies. She is instrumental in developing the cardiomyopathy center at Tufts with the goal of providing the most expert care, education, and support of patients and caregivers with advanced heart failure. She serves on the board of directors of the American Heart Association of Heart Failure Nurses, providing leadership and education to the heart failure nurses nationally. And so Linda, she's going to be the moderator tonight. Let me run through a couple of slides on some best practices for webinars, give you some information, and then I will turn it over to Linda and the two doctors, and they can take it from there. So just so you know, monthly we have a patient support group. It's the second Thursday of every month at 6 p.m. It's open to anyone and everyone. And we are actually trying to expand the capability there to have breakout rooms to support, if loved ones, spouses join and they want to speak with someone, that we have one of the spouses so they can focus on, how it is to be a caregiver and what to do. So we have that there for you. We have a series of heart failure awareness campaigns. Webinar 1, which was last month, which was talking about what is heart failure, what are the types, symptom management, and treatment diagnosis. That webinar is recorded and it's available on the Heart Brothers site. Go to heartbrothers.org and you should be able to find the webinar. The webinar today is going to be, as we spoke about, heart failure awareness, heart failure risks, factors, mitigation, lifestyle changes, and understanding and navigating insurance. And next month, on the third of the series, will be on April 27th. We still haven't finalized the time because we're trying to make sure it meets the doctors and the person from NEDS who's going to join us. It's going to be heart failure awareness, end-stage mitigation. It's going to talk about heart transplant and organ donation. It's going to be joint with New England Donor Services, as April is Organ Donation Month. And then culminating our heart failure awareness campaign, we're going to have a heart failure awareness 5K run walk event. It's virtual. Yeah, anybody can join and participate and help raise funds for Heart Brothers. More information is available for that, again, on our website. And the date for that is the early May. I want to say May 7th through the 13th, and it's virtual. You have 7 weeks to walk or run 5K. And so I want to thank our event sponsors. They're TransMedics, CareDx, and Cytokinetics. Appreciate for their support. I just wanted to say that please note that what we share in these webinars is offered by medical professionals. They may not be directly applicable to your specific condition. Please consult with your physician at treatment center regarding what approach and strategy is best for your specific condition. Do not change your treatment regimen based on the information provided here. Hopefully that's clear and makes sense to everyone. And for available resources, you can go to our Heart Brothers website. We also have Heart Brothers House, which is a facility in downtown Boston on a first come, first served basis. We have 2 luxury apartments that are they're walking distance to all the major transplant centers in Boston. You can go to the website, look up Heart Brothers House, and get on the web and go register to get a room there. It is pretty inexpensive. I think it's $45 a night, including parking. There's a required minimum 3-night stay on that. More information on that's available on our website. And please join us for our next patient support group, April 12th. And our next webinar, which is heart failure awareness therapies. So I'm going to stop my slide for a second here and just cover a couple things for best. Please put your phones on mute. If you have questions, use the question function. If you want to make any comments, use the chat function. Go to full size on your screen. And with that, I'm going to turn it over to Linda, and you're going to give me a second to get the next slide ready. Linda Ordway, take it away.
Thank you, Hamid, and good evening. I think it's good evening for everybody, unless you're on the West Coast. I'm Linda Ordway, and I am thrilled to be part of this webinar series that is just amazing topics, amazing speakers for patients. And, you know, my role is really to just help moderate and facilitate. We have 2 expert speakers on their topics for you tonight. And I just want to, Hamid did a great job covering all the best practices. So really, I just want to make sure, you know, to type in your questions, make sure to type in your questions in the chat. And I will be fielding those for everybody. And you can do that as the presentations occur. And I'll be keeping track of that, as well as at the end when we have Q&A. And I believe we'll be doing Q&A at the very end. So without further ado, it's my pleasure to introduce Dr. Muller as our first speaker. Dr. Muller is an advanced heart failure physician and has been a practicing cardiologist for 34 years. He's currently with the Albany Associates in Cardiology. He's a board certified in cardiovascular disease and internal medicine, as well as echocardiography and cardiac CT. He's a fellow in the American College of Cardiology and the American College of Physicians, and a founding member of the Society of Cardiovascular CT Scanning. He has been focused on the treatment of advanced heart failure for the past 10 years. And he completed his internal medicine and cardiovascular training at the Methodist Hospital and Downstate Medical Center in Brooklyn. He served for 25 years in the Air Force and National Guard and completed numerous deployments, retiring as the air surgeon for New York. In addition to his cardiovascular work, he serves as a member of the New York State Board for Professional Medical Conduct. Without further ado, Dr. Muller.
Well, thanks, Linda, and thanks to all for inviting me to participate in this. So my job tonight is to talk a little bit about what are the risk factors for heart failure. And I've got a couple of slides, and Hamid, I'm going to ask you to kind of bounce back and forth amongst them just to help highlight some of the issues that we need to cover tonight. I think probably would be best to actually start with slide 3.
Okay.
Just to get everybody grounded in, you know, what it is we're talking about. That's the one. So, you know, this is a basic diagram of the heart, and the heart, as you can see, it's basically 2 pumps that are attached together. And the side in blue, which is the right side of the heart, its job basically is to pull blood back from the body and pump it into your lungs where it picks up oxygen. And then the left side of the heart, which is what most people think of as the business end of the heart, its job is to pull that blood from the lungs and then pump it out to the rest of the body where it's needed. And so when heart failure occurs, primarily it's a problem of the pumping ability of the heart in some fashion. Most often the left side, the left ventricle, but sometimes it involves the right side as well. And it can occur in any of a couple of ways. So you can have a primary weakness of the heart, that is an inability of the left ventricle to effectively pump blood vigorously enough, or that pump can be stiffer than normal, in which case it can't fill with blood as well as it should, and that makes it less efficient as a pump and less able to pump blood out to where it's needed. And most people who have heart failure have one or the other, or in many cases, in fact, a combination of both those types of problems. That is a pumping problem or a filling problem. So Hamid, let's go back now to the first slide. Great. What are the basic risk factors for developing heart failure? Well, first and foremost, there's coronary disease and all the things that lead to coronary disease, like high blood pressure, for instance, high cholesterol, and smoking, and all the things we talk to patients about on a daily basis that can lead to heart attacks and angina. So how does coronary disease cause heart failure? Well, it can lead to heart attacks, which in turn leads to chronic damage to the heart muscle, and therefore you lose some of that pumping ability. I often use car engine analogies when I talk to patients about heart failure, because I don't know too many people in the US who don't understand cars. And so if your heart is supposed to be an 8-cylinder engine and you have a heart attack, suddenly you may only have 4 or 5 cylinders instead of 8. You still have an 8-cylinder chassis that has to be moved around by that heart, but you've only got 4 or 5 cylinders to do so. Okay, and that's what heart attacks do to cause heart failure. You lose some of that pumping strength, some of that pumping ability. High blood pressure. How does high blood pressure lead to heart failure? Well, obviously it can lead to heart attacks, but over time, high blood pressure puts a lot of strain on that heart muscle. Okay, that heart is a muscle, just like the muscles in your arms and legs. And if that muscle has to work against higher than normal pressures over a long enough period of time, that heart muscle starts to fail. Just like if your arms and legs had to work and carry or push against too heavy a load over a long period of time, those muscles are going to fail. Well, the heart can eventually fail if you have high blood pressure that hasn't been adequately treated over a long enough period of time. Okay. Then we get into the problem with heart valves. Hamid, why don't we go to that, I think it's the 4th slide. No, that's the 2nd slide. Next one. Great. So this is another diagram of the heart, but here you can see that it outlines that there are 4 heart valves, 2 on each side of your heart. And the valves in your heart are very much like the valves in your car engine or the valves in the plumbing in your house. Their job is to regulate flow. And they're to keep blood flowing in one direction only. Sometimes, for any number of reasons, one or more of those valves can stop working properly. And the problem can be one where the valve doesn't open as well as it should, or it can be one where the valve doesn't close properly. In either case, the heart has to work harder in order to get enough blood moving forward to meet your body's needs. And if that valve problem gets severe enough over a long enough period of time, then just like with high blood pressure, the heart muscle can't handle that stress, that load any longer. And so the heart starts to fail. You develop heart failure. And that can occur with problems with any of these 4 heart valves. People often hear about things like aortic stenosis or mitral insufficiency. Those are probably 2 of the more common ones that we run into in adults in the US. But problems with any of these 4 heart valves can eventually lead to heart failure. And again, because it increases the work the heart has to do over time simply to meet your needs. I mean, if we can go back to that first slide, that'd be great. Another common cause for heart failure is inflammation of the heart muscle, or what we call myocarditis. And that can occur for any number of reasons, but one of the most common ones is infection, particularly viral infections. And there are lots of viral infections that can, under the right circumstances, cause myocarditis. In fact, one of the most common ones we've run into over the last 3 years is COVID. And particularly with the newer strains, we've seen an increased incidence of patients developing myocarditis from COVID infections, which has then led to damage to the heart muscle, which in turn has led to heart failure. But other than COVID, there are lots of other viruses that can cause this. Flu is a big one. And many of the viruses that actually cause a common cold, under the right circumstances, can lead to damage to the heart muscle, that inflammation, which in turn can then cause heart failure. Another potential risk for heart failure in some patients is congenital heart disease. That is, heart problems that you were born with. So as I'm sure many people who are listening are aware, you can often be born with holes in your heart. And those holes interrupt that normal one-way flow of blood that I was talking about before. And over time, that increased inefficiency puts a strain on the heart. And if that strain is big enough over a long enough period of time, the heart muscle begins to fail and you develop heart failure. And there are any number of congenital problems that can lead to this over time. We don't have time tonight to go over all of them, but that's a major cause of heart failure in some folks. Heart rhythms, abnormal heart rhythms can sometimes lead to heart failure for a couple of reasons. Many of the heart rhythms that lead to heart failure usually cause the heart to beat much faster than normal. In addition, sometimes those rhythms also cause the heart to not only beat faster, but beat very irregularly. And that disrupts the normal synchrony between the upper and lower parts of the heart. And that interferes with normal blood flow. And that can therefore cause a backup of fluid into the lungs. When you have a problem, say like atrial fibrillation or a persistently fast heart rhythm called a tachycardia, what happens is the heart is beating so fast in many cases that it simply doesn't have enough time to fill up with enough blood to pump out to meet your body's needs. And as a result, things back up, just like we get backups in other types of plumbing, and you can develop heart failure. And in addition, over time, if those rapid heart rhythms last long enough, just like if your arms and leg muscles get overused, they cramp up and stop working on you, same thing can happen with the heart. Okay, if the heart is overworked long enough, the heart muscle can fail. So heart rhythms are frequent and very serious cause of heart failure, but also fortunately a problem that we usually can easily fix. Now, there's the other diseases and other problems, and let's go to that second slide. Great. These are important causes of heart failure. They're fortunately far less frequent, but it's the sort of thing that in the right populations we have to think about, because if you don't think about it, then you don't diagnose it and therefore you can't treat it. HIV. Untreated HIV is a known potential cause of heart failure for much the same reason that other viral infections can lead to heart failure. Okay. Thyroid disease is a well-known cause of heart failure, and it can be either underactive or overactive thyroids. The heart is exquisitely sensitive to thyroid hormone, and we all live within a fairly narrow range of normal thyroid function. And too much or too little can easily disrupt heart function and lead to heart failure. Sometimes we have patients who develop severe iron overloads in their system, and that can lead to deposits of iron in the heart. And those deposits can disrupt the normal structure and function of the heart muscles. And that is a potentially important cause of heart failure. And then finally, there's a condition called amyloidosis. And amyloidosis is very interesting. We had previously thought it to be a pretty rare illness, and we only saw it occasionally in older men. And it turns out that amyloidosis is substantially more common than we think it is. There are several types of amyloidosis, some of which can occur spontaneously and some of which are inherited. But they all lead to the body making too much of this protein called amyloid. And when that happens, that protein can get deposited in various parts of the body. And one of the favorite places for it deposits is in the heart muscle. And when that happens, it disrupts the normal structure of the heart muscle. And when that happens, the muscle can't contract properly. And you end up with these hearts that can look very big, but are very flabby. When you look at them on an ultrasound, the heart is contracting very weakly, even though the heart muscle looks very thick and you would think it would be contracting very vigorously. It's quite the opposite. The heart muscle is much thicker than normal because of all those protein deposits. But because of those protein deposits, the heart muscle can't contract properly. And the good news, up until a number of years ago, amyloidosis was not something we could do much about, other than in some cases doing a liver transplant, believe it or not. But these days we have a variety of medications that are available to treat amyloidosis and to not only arrest the problem, but actually make it somewhat better. And so these days it's a very, very treatable disease. So that really covers, the major risk factors for what can lead to the development of heart failure in folks. It's not meant to be an exhaustive discussion. I just want to kind of give you all an overview, and then I'll be happy to try and address any questions any of you may have.
Thank you, Dr. Muller, for that very thorough review of the causes of heart failure. Our next, and again, I'm just going to remind people that we're going to be taking entertaining questions at the end of both sessions. So there'll be plenty of time for that. And please remember to type your questions into the chat screen. Next, it is my pleasure to introduce Dr. Coplin. Dr. Coplin is is the Vice President for the Specialty Transformation and Medical Director, Capital District Physicians Health Plan Incorporated, so CDPHP. And he joined this organization in 2019 as Senior Vice President, Specialty Transformation and Medical Director. In this role, Dr. Coplin promotes and monitors the evolution of an enhanced CDPHP, specialty provider relationship, including value-based payment models and the deployment of appropriate support services. He also assists with the implementation of key initiatives related to medical management and quality improvement, and the introduction of innovative cutting-edge technologies to decrease variability and patient management and the delivery of health care. Prior to his current role, Dr. Coplin served on the CDPHP Board of Directors and various committees for more than a decade. He's a highly respected board-certified cardiologist. Dr. Coplin was in practice for over 30 years at Albany Associates in Cardiology, St. Peter's Health Partners Medical Associates in Albany, New York. He's a fellow of the American College of Cardiology, a founding member and fellow of the American Society of Nuclear Cardiology, and previous counselor of the American College of Cardiology for the New York State chapter. Without further ado, Dr. Coplin.
Thank you. I really appreciate being invited to talk to this organization. I've been hearing a lot about it over the years and been very anxious to potentially be part of this. I'd like to start attending these meetings on a regular basis, even when I'm not one of the speakers. I think it's a great organization. I think going through a transplant of any kind is obviously a major life-changing event, not just for you, but for your families. And to have an organization like this that you can get information, but also exchange information is just a tremendous opportunity. Before I get into kind of talking a little bit about CDPHP, and insurance in general, I just want to make it clear, I'm not really an insurance expert. I've been doing this for a while. I've been on the insurance side now for about 3.5 years, but I'm mostly in program development and strategic planning, but I have worked as a medical director for at least 2 of those years and have been involved in it. But as long as I've been doing insurance, it's still confusing. And we'll talk a little bit more about that. A few points I want to make, before I even get into the talk. No one knows how insurance works until you need it. That's something that has to change. You have to be an informed consumer. And we'll talk a little bit more about that. The other point I want to make is that your doctor, while they're great to go to and rely on for your care, they don't know anything about insurance. Do not listen to them. Do not seek their advice. You could probably pick a person off the street and they'll know almost as much about insurance as the doctor does. I can say that in 33 years of practice, I never looked to see what anybody's insurance was. I was completely agnostic as to their insurance when I was practicing. And even being on the board of an insurance company and on committees, the details of insurance are very complicated. That being said, CDPHP is a unique organization. We were physician founded and physician governed. We would be illegal nowadays. There'd be a conflict of interest, but back when the physicians locally wanted to start the health plan, they allowed it. It's member focused, it's community based, and it's not for profit. What the physicians no longer have an active financial interest in the company. What makes it unique though, is that by charter, 51% or more of our board has to be practicing physicians. To give you some idea what goes on nationally, only about 6% of people on boards for all the insurance companies nationally have anybody that has a background in healthcare, which is kind of frightening to think about. And I think having more physicians involved, in the delivery of insurance, but also setting up policies for insurance. At the end of the day, all physicians, even if they're on the business end, will always be a patient advocate for the most part. And I think we need to move toward having more provider and experienced people on the management side of insurance. We care for over 400,000 members in this region. We're the largest insurance company and have the largest market share in this region of New York State. We were one of the first enhanced primary care networks in the country, patient-centered home, whatever you want to call it. The national patient-centered home was actually based on our patient-centered home. We testified in front of Congress about 15 years ago. Most of our physicians locally are in the EPC network. We've been consistently named best company to work for in New York State for over 15 years. We're always #1 in customer satisfaction by J.D. Power in this region. We consistently earn 5 out of 5 stars for our Medicare Advantage plans, and that's the highest ranking in New York State, and actually one of the highest rankings in the entire country. There's just Kaiser and a couple others that are at that level with us. Most of all, though, we are very consumer-driven, very patient-focused, and focused on delivering true value in healthcare to our members. And that's something that needs, again, to be brought into the healthcare system. We all pay premiums, but we don't get a lot of value. Next slide. As I said before, unfortunately, healthcare is very complex. And I can give you some generalities on this discussion, but again, keep in mind, it varies company to company. And it also, varies within a company depending on what your contract calls for. There's multiple lines of business in an insurance company, which again, most people don't realize. You've got Medicare, you've got Medicare Advantage, you've got Medicaid, you've got commercial, you have ASO, which are the self-insured companies, and then you have HMOs. And they all have different formularies. They all have different policies. And so again, it gets very confusing very quickly. Next slide. What are the variables? Well, there's in and out of network coverage. And this is another point to really take home. Your doctor may send you to somebody that they usually use. So when they want a transplant, they send you to this institution. Well, that's great, but that may be out of your company's network. And so you may not be covered at that institution, and you may have to go somewhere else or work out an arrangement with where they want to send you based on that provider. Sometimes we can do single case agreements, so you can go out of the network. But in network and out of network is a real critical thing to know about right off the bat before you get into any kind of healthcare. Prior authorizations. There's a lot of things, especially if you're in network, that you can just go and get done and doesn't require prior authorization. But if you're going out of network and for certain high cost items and certain high cost drugs, you do have to get prior authorization. And again, a lot of times your doctor is not aware of that. And they may just send you to get a test or send you for a transplant evaluation or send you, for whatever, and they just send you. And they'll do that without a prior authorization. You'll end up getting there and all of a sudden you'll get a bill because it was never approved. So again, before you start getting out of town, before you get into big procedures, a lot of consultants out of town, anything like that, even within town, just always check, does it require the prior auth? And do not assume your doctor knows the answer to that. High deductible plans. Again, there's a mandatory out-of-pocket expense, the deductible, before your insurance kicks in. And again, you've got to be aware of that. And again, some people have high deductibles, some people have no deductibles, like in an HMO. Medicare Advantage varies a lot. Medicaid has no copays. But it varies by your policy. Again, there's a maximum out-of-pocket expense with most policies, but again, that varies tremendously depending on your policy. A lot of people don't understand the difference between a copay and co-insurance, and it's an important distinction. A copay is a fixed fee the provider receives for the services provided. So, for instance, if you get admitted to the hospital, your copay may be $100. Co-insurance is a fixed percent of the total cost, which is your responsibility for the services rendered. So let's say you have a cost share when you go to the hospital, and let's say your cost share is 10% and the bill is $10,000, you will owe $1,000 of that. And obviously, if you go to a hospital, especially out of town, it's not going to be $10,000, it's going to be a lot more than that. So it's always important, if you have cost share, to really understand what the potential bill is and what your potential part of that bill is based on your cost share. But a lot of times physicians and most people don't really understand the difference between copay and coinsurance, and they just kind of intermingle them, and they're very different, and your potential liability is very different. Again, copayment is fixed. Coinsurance is variable depending on the total cost. Your percentage may be fixed, but the total cost is not. And the actual amount that you're at risk for in each situation is defined by your policy. Next slide. I hate to say this, but nowadays in healthcare, everyone needs an advocate. And if you come away with no other message tonight, it's that everyone needs an advocate. You can be your own advocate, but that's very difficult if you're very sick. It could be a family member. It can be your provider, your doctor, they can help, and they can certainly be an advocate getting you the care you need. And I would encourage you to take advantage of care managers at your insurance company. They can be your go-to person, and they know how to navigate the system. You need to be aware of your coverage and the potential costs. And again, the policies differ company to company and by line of business. Verify in every case that your providers are in network. So if you're getting referred to somebody, even in your community, they may not be in network. And again, that triggers a whole bunch of bills and a whole lot of, heartache. So just always keep that in mind, in network and out of network. And again, you may have out of network, you may have tremendous out of network benefits where none of this is an issue, but for a lot of people, that's not the case. Ensure that your prior authorization has been addressed if you're getting something that needs prior auth. If you're going out of network, again, be sure you have out of network coverage and get prior approval if needed. Be aware of the coverage that your insurance company provides you for pre and post care, out of town coverage, and that includes hotel stays, meals, transportation. And that's not just for you, but it's usually for a family member as well, especially in something major like a heart transplant. Next slide. Let's talk about care management, in the utilization review. Next slide. Let's talk about LVAD and heart transplant to start, because those are the two big ticket items in the cardiac space. Our members are referred to a center of excellence if they need a heart transplant. Those centers of excellence are defined by Optum, and they have to meet certain criteria in terms of outcome. That includes mortality, infections, length of stay, readmission, and also volume. And so they're selected fairly carefully. Now, some major programs elect not to be a center of excellence, or they don't have one of the components that you need to be a center of excellence. We still take that into consideration. And like if somebody wants to go, say, to Mass General and they're not considered a center of excellence, we're likely to make an exception for that. But again, every insurance company differs. LVADs do not have to be performed at a center of excellence, but they do have to be at a participating facility. So they have to be part of our participating network. They don't require prior authorization unless you're not only going for an LVAD, but you're using, you're also going to be evaluated for a heart transplant, where the LVAD is anticipated to be bridging therapy to get you to a transplant, as opposed to destination therapy, where there's no plan for any intervention beyond LVAD. Services covered include evaluation for transplant, physician office visits, diagnostic testing, left and right heart catheterization, the transplant surgery itself, 12-month follow-up for all services after transplant. The cost share for a transplant or an LVAD is dependent, again, on your contract. And again, that takes into account copays, coinsurance, deductibles, et cetera. And somebody just mentioned it's generally better to be on Medicare at the time. It's true, Medicare, you can go anywhere and none of these things are an issue. Medicare makes it very easy to go anywhere you want. When a request is received for an evaluation at CDPHP, the utilization review nurse refers the member right away to our internal care management department for ongoing support and process navigation. So you will be assigned a care manager as soon as we know that you're at risk for an LVAD or a heart transplant. In fact, anybody that has end-stage heart failure, we try to hook up with a care manager. Again, as I mentioned before, travel, lodging expenses are covered for Medicare members, including their support person during the evaluation and post-transplant. And that includes regular Medicare as well as Medicare Advantage. Next slide. And again, you can end up with a care manager from utilization review. You can actually call and request a care manager. Your provider can send you to a care manager. We may often pick that up as an inpatient when all of a sudden, our care managers are in the hospital, they're reviewing the charts. And if it's clear that you may need an LVAD or a transplant, or you do have end-stage heart failure, we'll often just contact you. We'll make the outreach and get you hooked up with a care manager. And you will have that care manager for good. You won't be switched between care managers. You'll have a personal relationship with that care manager, and they will be your advocate from the day you start. Now, Every plan has care managers. They might not have as many inpatient ones as we do. They might not have as many in general as we do, but I don't care what your insurance is, there will be care managers. And I would strongly encourage you to build a relationship with one, because they can be your go-to person no matter what. Again, the scope of services for a care manager: they coordinate care with providers, they provide member support education, they can connect you to specialty services, including nutritional support, smoking cessation, cardiac rehab, and BH and stress management. And again, we focus a lot on BH because it's very unusual to not have some element of depression, either after heart attack, with heart failure, after bypass surgery, valve surgery, and certainly after transplant. And for most people, having a heart attack or going through any of these events or developing heart failure is the first time they've actually had to address and think about their own mortality. And there's a lot of stress and a lot of depression often that goes with that. And so I think BH has to be included in this way more than it's been included to date. And again, cardiac care managers with a lot of experience can assess member health literacy, so they can get a feeling for where they do need to intervene. And they can involve, the providers, family members as appropriate. And again, social work is also available to assist with any financial challenges. And along those same lines, it's interesting, we actually, as a medical director, I actually rounded in the hospital for a couple of years. And it was very interesting in talking to patients. They're never up all night worrying about, am I going to be okay? Am I going to get through my surgery? They're up all night worrying, can I pay for this? And we have care managers actually embedded in we have a financial office in each of the major hospitals, and they will come to the bedside and they will tell you exactly what your bill is likely to be and what your share of that bill is likely to be. And 99% of the time, it's way less than people anticipate. And even if you can't pay it, we'll work, again, the care managers will help you get through all those financial challenges. But that's not the stuff we want keeping patients awake at night. We want them focused on getting better, on their families, and on getting through whatever challenges they have, not on worrying about how we're going to pay for this. And so, again, before you get into anything major, your insurance company, I don't care what insurance company you're with, they should be able to give you a pretty accurate idea of what it might cost. They know how the average length of stay, they know the typical charge, they know what your cost share is, if any, they know what your copay is, if any. If you're going out of network, again, the cost share may be very different out of network than in network. They can, again, calculate that, but they can always give you a pretty accurate picture of what your likely financial responsibilities will be. So don't ever hesitate to take advantage of that. Also, if you can, if you have a choice of different facilities and they're all equal, if you can go to some place that has the same EMR as your provider, it makes exchange of notes and stuff much easier. So like if your provider's on Epic and they're sending you out of town to an institution that's on Epic, everything is infinitely easier as far as exchanging records. They don't need to have you involved at all. They can pick up records from each other seamlessly. Next slide. I just wanted to spend a little bit talking about some of the strategic initiatives we're doing and what we've seen as a result of some of these initiatives. And I don't want to spend a lot of time on this, but I just want you to kind of know what's out there. If you look at CHF, it's the most common cause of hospitalization in the United States for people over 65. And it's the highest rehospitalization rate among all medical conditions. The readmission rate, and that's 30-day readmission rate, for heart failure is actually up to 26.9%, which is an astounding figure. Next slide. We gave each of the major offices in town and each of the hospitals what we call a REDS device. And a REDS device, you can see what it looks like on a patient on the far right. It allows non-invasive assessment of lung water. And lung water indicates volume. And if you're in heart failure, again, as Dr. Muller was pointing out, one of the first things that happens when the left ventricle is not pumping blood adequately, things back up and the pressures in the lungs go up because the lungs empty into the left side of the heart. And so the lungs become congested with fluid, and that's what makes you short of breath. That's what shows up on a chest x-ray. But this allows to get an accurate, reproducible, and actionable measurement of lung water, which actually correlates highly with a catheter reading. So rather than have to put a catheter in invasively, this will actually correlate very highly just by doing it without even taking your shirt off. Next slide. This is just we tend to look at weight and edema. And this is a heart failure curve that's really important to understand. I want you to understand the decompensation and hospitalization here. If you see that, it's not a gradual decline, it's a cliff. And once your weight starts going up, and once you start getting more edema, you're within about 7 days of falling off the cliff. So it's not a really great way to follow heart failure, but it's all we've had. And if you look at clinical judgment and clinical assessment of heart failure, so you take a heart failure clinic where everybody there just does heart failure. So you take an expert like Dr. Muller, you take the nurses there that do heart failure. If you try to assess somebody's volume status clinically, the doctor gets it right 60% of the time and the nurse is 50-50. So it's very hard to really follow somebody clinically because they can often look okay and still be about to go into significant heart failure. If you look at pressure and volume status change all the way down on the far left side of this graph, that gives you like 3 weeks warning. And so if you can get these lung water readings on people, you could potentially catch things much, much earlier. We also know that when people leave the hospital in heart failure, 50% of them are still in heart failure. Because again, they may look better, they may have diuresed a lot of fluid, getting some Lasix in the hospital, but a lot of them are still in heart failure, and sometimes not insignificant heart failure. And that's one of the reasons a lot of them get early readmission. And so again, if somebody could get a reading in the hospital, and as I said, we put these devices in the hospital, if you can get a reading before they go home, if that shows that it's still real high, keep them in the hospital another couple of days and get more fluid off. Also, by getting a reading in the hospital, when they come into the heart failure clinic a few days later, you've got a baseline from where they left the hospital, and now you know where they are now that they're on the outside. And again, it allows you to adjust the medications more accurately. Next slide. So this actually gives you a number, and we know that, 36 to 41, is possible. Hypervolemia, mild fluid overload. Over 41 is definite, and over 50 is severe. So if you come in short of breath and you have a history of heart disease, it doesn't necessarily mean you have heart failure. So if you come in and you have a normal lung water reading, then you're probably not in heart failure. There's probably another cause for your shortness of breath. Also, if you have low, maybe even moderate volume overload, you might be able to get some Lasix in the emergency room. And if you diurese and your lung water reading comes down, you could get discharged rather than admitted, and then go to your heart failure clinic or walk-in clinic with your cardiologist the next day. And again, you could get more IV Lasix if you need it. And again, we could follow this lung water reading. Dr. Muller was telling me about a patient they saw in the office that actually looked pretty good, but the lung water reading was up. And when they asked the patient about it, they acknowledged that they were actually feeling pretty good and they weren't taking their Lasix. Another one said, yeah, I've been out to dinner with my brother who was visiting in town, and we kind of had some dietary indiscretion. But looking at those patients, you probably wouldn't have picked it up, and their first warning may have been an admission. This allows you to follow it. And patients really like it. They like coming in and saying, what's my number? It's tangible, and I think compliance is better, and I think follow-up is better. But it is actionable. And so, as I say, we've put these in all the cardiology offices, and we've also put them in the hospitals. Next slide. This just talks about that critical time for follow-up is in the first few days, because a lot of these people do go home and they're still in heart failure. And it talks about the importance of having a heart failure clinic and using the REDS device. And together, they can be a very powerful tool. A lot of cardiologists do not have dedicated heart failure clinics. And if you're followed in a cardiology group that does not, again, I would encourage them to do that. Both of our cardiology groups actually have walk-in clinics where you don't need an appointment. If you're having a problem, or you call your primary and they think you have a problem, they just say, go to the walk-in clinic and you'll be seen right away, and you will be. Heart failure clinic is different in that these are people dedicated to heart failure care. So these are advanced heart failure specialists, both cardiologists and nurses. And having a dedicated team, I think, is extremely important. Next slide. This is comparing the readmission rates for two groups in town that are similar in size, one of which is using REDS and using a heart failure clinic, and the other has a very active walk-in clinic, but no heart failure clinic and no use of REDS. The one group that's doing both has been able to get their readmission rate down to 5%, which is as good as anybody's reported in the country. Again, keep in mind that nationwide it's like 18 to 22%. The group that has the walk-in clinic is still doing better than national average, but is almost 3 times the readmission rate of the group that has the heart failure clinic and is using the REDS device. And this is just in the first year. This is not a large number of patients. And yet as a health plan, we prevented 46 admissions in the group that was using both REDS and the heart failure clinic. Next slide. I'm going to spend 2 seconds on this. This is another company called Bodyport. Next slide. They have this amazing scale, and it looks just like a scale. It looks like an Apple scale. And, it's very cool, very technical, very elegant. And one of the problems with REDS is that you only get a reading if you go to the office. We would like to be able to get readings every day so you can see early trends and not wait until somebody's already up. And this allows that. And just by standing on this scale, just show me the next slide. This is what this scale can do. Obviously, it gets weight gain, and that's kind of a proxy for edema and fluid accumulation. But it can actually measure third space fluid changes and actually, again, be a surrogate measurement of lung water. It can measure pulse rate. And again, if it's high, that especially like in advanced heart failure, and especially if people are decompensating, the pulse rate goes up. It can also measure pulse rate variability, which is down in the setting of heart failure. It can also measure postural sway when patients are standing on it. That may reflect orthostasis, drops in blood pressure when patients stand. And that's a common problem when people are on all the medications you need to be on. The other thing that this can do is predict risk for falling. And, we're probably going to start a fall risk program, and I'm probably going to use this as one of the devices to try to assess the risk to see who should be in that program. And so this is really exciting, and this is state of the art. We'll hopefully be one of the first communities in the country using this, but it's got FDA approval for measurement of all those things. Next slide. Again, this can be deployed at home. It allows daily results so we can follow trends rather than isolated readings. We'll use this initially in the highest risk patients, again, to help avoid admissions and readmissions. And again, I'm probably going to want to put these in heart failure clinics, but also put them in dialysis centers. And again, it's probably not the topic to get into now, but there's tremendous fluid shifts with dialysis, both chronically and acutely. And again, to be able to assess volume status in dialysis patients would be enormously helpful. Next slide. Next slide. I don't want to spend a lot of time on cardiac rehab, except to say that heart failure has been ignored in cardiac rehab. Cardiac rehab in general is grossly underutilized. Nationally, maybe 16% of people get cardiac rehab of those eligible. And they're now making this a HEDIS measure, which means the government has said this is a very, very important measurement that everybody's going to be held accountable for. It doubles 5-year life expectancy. It improves quality of life. Participants are 40% less likely to get another cardiac event. And again, a 30% decrease in 1-year readmissions. And yet nobody's doing it nationwide. So we've had a big push locally. We're working with the Department of Health and with CDC to try to improve cardiac rehab in New York State. They're again using our program as an example. And we're part of the Million Hearts Initiative as well. Next slide. Why are so few people doing cardiac rehab? There's a lot of reasons, but one is high copays. One is the distance involved in traveling and who's going to make the drive. Inconvenient schedules. If you're limited to brick and mortar, you have to be seen at their hours. And if you're working, it might not be convenient. Or if your spouse is working and they're the ones that drive you, it might not be convenient. If you're back to work, you have to miss work to go. And then long wait lists. If you filled every brick and mortar cardiac rehab facility in the country to capacity, it wouldn't begin to fill even 50% of the need. So there's just a huge need and not enough capacity. And especially locally, Albany Medical Center here does not have a cardiac rehab program, so it's limited to St. Peter's. And the wait lists are very long. And there's one in Albany, one in Troy. And if you looked at patients' willingness to go to one or the other, you would think you were asking them to swim across the Hudson River to get to the other one. They will not cross the river. So again, it's been a real problem locally, but this is the same thing is true nationally. So what have we done? We were one of the first companies in the country to start virtual cardiac rehab. And we were going to start that even before COVID, but obviously with COVID, that became even more imperative because cardiac rehab shut down completely during COVID. So what else have we done? We've waived copays for cardiac and pulmonary rehab. There's only 3 companies in the country that are doing that, but more and more are seeing the need to do that. And at the end of the day, you know, they always go to the hospital and to the doctor's offices to run cardiac rehab. They lose money on cardiac rehab. The hospitals are not, you know, it sounds bad, but a priority for them is not preventing readmissions. The doctors get nothing, and it's just a cost for them. And so who really benefits other than the member from cardiac rehab? The insurance company does. We have fewer readmissions, less recurrent events, healthier patients in the long run. And they should be coming to us to help pay for cardiac rehab and to help get people into cardiac rehab. So waiving cost shares, I think it's a no-brainer. And I think we should be waiving cost shares for a lot of things. Heart failure, again, most of this is for coronary disease, valve replacements. 20% of our members in cardiac rehab right now are heart failure. It's the largest percentage of any insurance company in the country right now. And we have waived all copays for CHF follow-up. Not just for rehab, but for any CHF follow-up. Our members do not pay a copay. Because again, I don't want CHF patients sitting home accumulating fluid. You know, I want them to come in when they need to be seen. We are funding, help funding walk-in clinics at both of the large cardiology groups. Again, so people can have same-day access without an appointment. If they're struggling, they just go in. So as an insurance company, we're putting money up front. You know, we're putting money where our mouth is to try to really make a dent here. And so far, the numbers have supported that investment. Aside from being the right thing to do, it's financially the right thing to do. And again, I don't want to display this as a battle between brick and mortar and virtual. There's plenty of room for both. And right now, some of the brick and mortars feel threatened by virtual, but the reality is, 85% of the eligible members locally are not doing cardiac rehab. There's more than enough business for virtual and brick and mortar, and some are better than others, and we allow people to switch once. So if you start in brick and mortar, you're doing better, you want to go back to work, you can switch to virtual. If you start in virtual and you're kind of uneasy and you want somebody to actually see you, you can go to brick and mortar. And again, if you're a high risk patient with severe heart failure or high risk for whatever reason, you'll end up in brick and mortar. We're selective in who goes into the virtual program. Next slide. Next slide. Next slide. I also want to point out that competition is good. The average enrollment time for cardiac rehab before virtual started was 3 months to 4 months. We've now got it down to under 7 days. And the studies are very definite. The earlier you get people involved and participating, the more likely they are to do and complete cardiac rehab. And so it's made everybody kick their game up a notch. This is an example of what's happened as a result of our rehab endeavors. If you look at the readmission rate for virtual and the readmission rate for brick and mortar, they're very similar. Overall, 12.8%. But you look at no cardiac rehab, 24% readmission rate. So again, we've prevented 27 readmissions in just the first 6 months. And again, just so you know, an admission or readmission is very expensive. So, if you just prevent 1 or 2, you've paid for a large part of the program. Next slide. The only point on this slide, we signed up with a company called Cure. They give simulated cases to all the doctors in the area, and they show them variability within their own group, variability within the community, and variability compared to national guidelines. We all talk about group practice. There's nothing group practice, in healthcare. you may be sharing office space, but you're in the room by yourself. You're around by yourself. You may run patients by one another, but you're by yourself. And the reality is doctors have never seen their data. They don't know they're off the curve. They don't know they're not following national guidelines. They don't know they're doing it differently than their partners. They've never seen the data. And so this is bringing this out to the community so they can see their data. And doctors are phenomenally competitive people. You don't go to medical school if you're not competitive. And nobody wants to be the guy off the curve. So this, without a carrot or a stick, just knowing you're off the curve changes behavior. Next slide. And again, physicians love this. They've never had anything like this. They actually get paid to provide, they get paid for their participation time, and they get CME credits, which again is unheard of, you know, in physician education. Next slide. If you look at SGLT2 inhibitors for heart failure, both for reduced ejection fraction and for reduced ejection fraction, we started out at 37% in the first round. By the third round of cases, we're up to 59%. And this is verified by claims in pharmacy. So it's not just the exam, we're actually seeing it in the real world. Next slide. Again, 17% decrease in variation. And by variation, I think one of the biggest challenges to healthcare is variation in care. Physicians don't want to do cookbook medicine, but I would maintain that they need to do cookbook medicine. The computer has to guide you. If you look at the doubling time for medical knowledge back when I graduated, it was probably 15 years. And it's now down to probably 16 weeks. Nobody can keep up with all that. And you need a computer to assist you and artificial intelligence to help guide you. And it shows when we do these cure programs, how much variability in care there really is. And that variability is dangerous. We have to address variability. A cure program will help do that. And the next thing I'm going to go over with you after this will, again, address some of that. Next slide. Again, 59% increase in use of SGLT2 inhibitors. And again, that's fairly recent data. So people are already acting on it. And that's both with preserved ejection fraction, meaning that the heart is still functioning fairly normally, as well as reduced ejection fraction, the appropriate use of ARNIs. Next slide. This is the company I'm really excited about that we haven't started yet, but we'd like to. Okay, it looks like we're over time. So I will stop. This is a company that will manage medicines. And I just want you to understand that only 30% of people with heart failure are on the right drug at the right dose. And by letting a company like this with AI-driven dashboards manage medicines, you get way better compliance. And I think that's going to be the future, because 30% is not acceptable. And I guess we'll entertain questions. Sorry, I went over.
That's okay. Thank you so much, Dr. Coplin. That was lots of information, and we have some really good questions. So I didn't want to miss that opportunity. If everybody can hang with us for a few more minutes. I'm going to ask, since you're the last speaker, I'm just going to ask one of you right now, and then go back to Dr. Muller, if that's okay. Dr. Muller, you're okay hanging with us for a few more minutes?
Yeah, absolutely.
Okay, thank you. So one of the questions are care managers automatically assigned, or does the patient have to ask for one? Because I think the key that everybody heard, and I know I perked up on this, is everyone needs, everyone getting healthcare needs an advocate, and boy, do we know that. So, my question to the audience was going to be, does everybody know that there's a care manager, with their insurance? Have they talked to them? But more importantly, one of the audience members did ask, are they automatically assigned, or is it something that you have to ask for?
Both. If you want one and you think you need one, or you're having major heart issues or major health issues, period, especially if you have multiple chronic diseases, you can call and ask for one, but otherwise they will be automatically assigned. Anytime they hear that somebody's being referred for a transplant, LVAD, in the hospital with end-stage heart failure, they will be referred.
And these are any insurances, you're saying, right?
For the most part, they should be, yeah. Okay. If they're using care managers.
And if people haven't had that, haven't heard that they've had one, they should be asking for one.
And the other thing to take advantage of is member services. All insurance companies have member services. And if you have any doubt of whether you need a care manager, who to talk to, call member services to start. they will be able to guide you to the right people.
Great, thank you. Dr. Muller, one of the questions, a general question, but then there were some specific ones within there. And I think just if you could speak a little bit towards, are there ways of mitigating or managing risk? So you talked about a lot of, the causes of heart failure, and clearly, in some cases, just like risk factors for cardiovascular disease anyway, there's some things that you can modify, and there's some things that are just unfortunately genetic and whatnot.
Sure.
And along with that, one of the questions specifically was, can a valve repair stop the advancement of the stage of heart failure?
Well, the short answer to that question is absolutely. That's an easy one. Yeah, if the individual's heart failure is largely due to the effects of the valve problem, then fixing the valve problem, and depending on the problem, there's any number of ways to do that these days, that generally will eliminate the heart failure problem. The problem you run into sometimes is that they've waited too long to seek attention. And so by the time the patient comes to your attention, the valvular issue is so far advanced that it's actually caused permanent damage to the heart muscle itself. And then it becomes a little harder. You can definitely make the heart failure better, even in those circumstances, by fixing the valve problem. But then sometimes you'll also need, a variety of medications and other treatment modalities like rehab and what have you, to help manage the residual problems after fixing the valve. But no question, keeping a close eye on any valve issue and intervening once you see it advancing to a significant level is going to keep people a lot healthier. And the same could be said of many of these other issues, keeping your blood pressure under control, keeping your cholesterol under control. That is all important for preventing heart failure as well as other heart and vascular related issues. As I say frequently to many of my patients, I'm a heck of a lot cheaper helping you prevent problems than I am fixing problems. And I think that's, I think that's the coda that we should follow.
So along with that, the specific question in regards to valve repair, one of the other questions was, what about a genetics-based or familial heart failure or cardiomyopathy? I couldn't remember if you spoke to that during your
I didn't really address that because it is kind of a much more isolated area of heart failure, obviously one that's very important to those who have it. But much less frequent a cause of heart failure than the other issues that I raised. The problem with the familial heart failures, the familial cardiomyopathies, is they are genetically determined. And unfortunately, if you inherit that gene, you're going to develop that problem. And you can preempt and try to intervene early with medication, but that's not necessarily going to prevent the progressive deterioration of the heart's pump function. That's the challenge there.
Okay. So one of the risk factors that's not modifiable, really. I mean, you can
Unfortunately, yes.
find out about it when one of your family members has it.
We're as I say to a lot of patients, we're not at the point where I can change your gene pool.
The other advantage though there is if you can identify it, it's important that people know they have it, because often the first sign is sudden cardiac death. And so even if you can't prevent the progression of the heart failure, if you at least know about it, you can get a cardioverter defibrillator early on, and you know that you're going to be facing a transplant or LVAD down the road, but at least you know what to expect, and you can intervene before somebody does get sudden cardiac death. And hopefully once they start having arrhythmias, we have cardioverter defibrillators and things that can help those patients until they get.
And the issue there is having a pretty high index of suspicion. If you've got a couple of other members of your close family that have had problems with heart failure, that's got to get the warning bells going off, both with you and your physician, to look further into this and see if genetic testing might be worthwhile and worth pursuing.
The other issue is that only about 50% of people that have familial cardiomyopathies and serious familial cardiomyopathies will actually be found to have a genetic defect. So there's probably something there, but we're not picking up on routine genetic testing and haven't been able to identify it. So again, it's still very important that those people get identified early. And amyloid, if you have a family history of early heart failure or a bilateral carpal tunnel disease, there's certain tip-offs to amyloid. And as Dr. Muller was saying, way more prevalent than anybody realized.
We used to think amyloid was the sort of thing you'd see, a couple times in your career. And these days I see amyloid a couple of times a month on average. And there's several different types of amyloid. There's what's called light chain amyloid, AL amyloid, and then there's what's called transthyretin amyloid. And the transthyretin amyloid actually has a couple of types as well. One is called wild type, or what we think of as old age amyloid. And then there's the hereditary amyloid. And particularly with those two types of amyloid, that's where you can see things like the carpal tunnel syndrome, the neuropathy. And I had a guy not too long ago who came into me and was starting to have problems getting around, and he was seeing a neurologist because he was having problems feeling his feet. And I tapped on his wrists, and I suddenly caused electric shocks when I tapped on his wrists. And I said, let's just get an ultrasound of your heart. And his heart, was big, but fortunately the pump function was still good. And we sent him for the appropriate testing. And sure enough, his neuropathy was not caused by his diabetes. His neuropathy was caused by amyloid. And we got him on the right treatment, and he's feeling a lot better.
One of the questions is, and I think this kind of fits in with this, and you may have already answered this, but should all patients with cardiomyopathy, or which patients with cardiomyopathy are the ones that should get genetic testing to protect their kids? Early identification.
In many cases of cardiomyopathy, it's pretty easy to figure out what the cause is. There's enough in the patient's history or background or the evaluations that you've done in the course of working up their cardiomyopathy that what's behind it, what the cause is. Okay. But there are cases you run into where, despite your various testing, it's not clear what is behind this, what triggered this. And particularly if you have, as Bruce mentioned, if you have other people in the family who've had a history of heart failure, or a history of, for instance, as he said, sudden death that was unexplained, or had a defibrillator implanted for unclear reasons. Those are the people where I got a pretty low threshold for sending them for genetic testing. And again, the problem there is we can fill books with what we don't know about the genetics here, because a lot of these people may have spontaneous mutations, and there are probably mutations out there that we just haven't mapped out yet. I mean, we know a lot, but we don't know a lot more.
Thank you. Well, I think we have time for one more question, and I have to say that there was a lot of interest about the REDS device. How long that's been around? Was it here 8 years ago? How many companies actually offer this equipment, and who they are?
Well, I won't try to steal Bruce's thunder, but I've been using the REDS for the last couple of years. It's an Israeli company. It was originally technology. It was developed by the IDF for other things, but it does turn out to be useful in detecting, increases in lung water, which is a sure sign of heart failure. It is a very good device. It helps greatly to have a baseline on the patient, because there can be a lot of inter-patient variability in what constitutes normal versus abnormal. So having a baseline on the patient is very helpful. And unfortunately, it is somewhat sensitive to the patient's body habitus. You know, if they are big barrel chested or have severe curvature of the spine, for instance, you know, rib cage abnormalities, or maybe, you know, implants in the chest, because it's designed to go over a specific area of the chest. So if there's implants in that area, you're not going to be able to use it. If they have very adverse anatomy, you're not going to be able to use it. It's a good device, but like with many of the devices we use, it's not perfect, and so we can't unfortunately use it on everybody. However, you know, we do have all sorts of devices that, you know, we can use to help us track lung water. I mean, I've got some folks with, you know, devices implanted, and I can tell when they went out to, you know, Wang Chung's Chinese, you know, bazaar the night before, because all of a sudden their numbers are off the wall. And the one thing that all of these technologies offer, REDS included, and I think Bruce will agree, is that they allow us to identify when patients are beginning to go off the rails long before they actually go off the rails. So we can intervene way earlier before they necessarily even notice that there's a problem or that they're having any symptoms. And that's, you know, that's the key to success. You know, it's a hell of a lot easier for me to keep you out of the hospital than to get you out of the hospital.
The other advantage is, you know, a lot of people don't live geographically close to a heart failure center.
Mhm.
And if you put REDS devices out in those communities, there's a Dr. Ben Simone and a few other doctors around the country that are actually managing heart failure clinics out in these remote communities using the REDS device, and having a primary care doctor or nurse in these communities that's comfortable working with him and managing these patients remotely. And again, that's been and they've been able to get their readmission rate way down just by that interaction, because it's not realistic that everybody can get into a heart failure clinic.
Well, I want to thank both our speakers. Amazing. Thank you for providing this information to patients that have been on the call. And Hamid, I'm going to hand this back to you.
Thank you. Thank you, Dr. Coplin, Dr. Muller, Linda, you guys were phenomenal. I know it went over a little bit, but we think the information that was provided was well worth the wait to hearing about it. There's still a lot of questions. I know people want to know, Dr. Coplin, about where they can get the scale and what the cost is and stuff, but I'll get that from you and I'll post it on our website rather than to take up time. I just want to thank everyone and say, please don't forget, next month, we're going to be talking about heart transplantation, advanced therapies for end-stage heart failure, and don't forget our patient support group, which is going to be the second Thursday in April. Thank you very much, and everybody have a fabulous evening.
Thank you.
Thank you. Good night.
Good night.